So there are several pharmacologic considerations for the recommendations that were included in the guideline. First of all, when you look at the clinical efficacy between the ticagrelor and clopidogrel groups, the clinical efficacy at the beginning of therapy is very similar, and the benefit of ticagrelor comes later in the duration of therapy. As well, there was discussion and debate at the panel with regard to the balance between the ischemic benefit of ticagrelor as well as the bleeding risk. So if you look at the data presented in the Plato trial between the ticagrelor group and the clopidogrel group with regard to bleeding, and the overall bleeding, the major bleeding, was very similar between the two groups. However, if you remove the cabbage-related bleeding and just look at non-cabbage major bleeding, there was an increase in bleeding in the ticagrelor group, as well as an increase in fatal intracranial hemorrhage in the ticagrelor group. So looking at the evidence that we had, we felt that the most benefit for ticagrelor was in patients who are at high ischemic risk. So for example, a Gray score greater than 140 or a TIMI score of 5 to 7, and a low bleeding risk, that they would be the patients who would benefit the most.